Why is it relevant for us to think about deafness? 1 to 2 out of every 1,000 children born in the UK have permanent sensorineural hearing loss caused by abnormalities of the cochlea or of the auditory nerve, while microtia, where the external ear does not develop properly, occurs in 1 out of approximately 8,000 to 10,000 births. And last but not least, temporary but recurring conductive hearing loss due to ear infections is very common in school children. Children who are deaf and hard of hearing are at high risk of language deprivation, meaning that they risk not experiencing language input fully. As a consequence, their language development is very likely to be delayed. Delayed language development, in turn, impacts the development of academic skills and social skills and has longer-term consequences with respect to employment and to physical and mental health outcomes. It's important to note that these risks are not a consequence of deafness per se, but rather a consequence of language deprivation. Deafness might not be avoidable, but language deprivation is. Why then do so many deaf and hard of hearing children, even those with mild or moderate deafness, experience language deprivation? Well, the vast majority, around 95% of deaf and hard of hearing children, are born to hearing parents who have no experience of deafness and who know no sign language, and who therefore find it difficult to communicate, at least initially, with their child using a language in the visual modality. In many countries, including the UK, the advent of universal newborn hearing screening has enabled the much earlier identification of deafness, allowing for earlier language and communication support. But most often, the advice is that the child should learn spoken language and use cochlear implants or hearing aids. Although both types of technologies have improved greatly over the past decades, they do not restore completely normal hearing, and so they're not a cure for deafness. While some children will benefit from assistive hearing technologies, not all will. There's great variability and unpredictability in deaf and hard of hearing children's language learning outcomes and in their subsequent academic attainment. Let's consider together 3 neuromyths that contribute to maintaining language deprivation and therefore to maintaining lower educational outcomes for deaf and hard of hearing children. Neuromyth 1. Using a cochlear implant allows children to regain normal hearing and to learn to speak so well that they will achieve age-appropriate language skills. Now, while many forms of poor vision can be corrected to normal by glasses or contact lenses, the same degree of correction is not possible for deafness. Cochlear implants work by bypassing the normal acoustic hearing process to replace it with electrical signals, which directly stimulate the auditory nerve. A child with a cochlear implant will need to receive intensive auditory training to learn to interpret these signals as sound and speech. And what they hear will never sound the same as what a person with normal hearing will hear. Hearing and speech perception and production skills show a wide range of variation across implanted individuals. What causes this range? Well, various factors, including duration and cause of hearing loss, how the implant is situated in the cochlea, and the overall health of the auditory nerve. But much of the variance in hearing and speech outcomes is simply unexplained. Similarly, although some implanted children will achieve adequate spoken language skills like grammar and vocabulary, many will not. And even when children are able to acquire a spoken language via cochlear implants, the listening effort is huge, resulting in significant concentration fatigue, which can cause more academic challenges. So let's remember, it might seem that if a child is wearing a device such as a cochlear implant, their hearing has been corrected to normal, but it hasn't. Neuromyth 2. Cochlear implanted children should not be exposed to a sign language because this will impede their ability to learn spoken language. It's true that in deaf and hard of hearing children, the brain regions that are primarily responsible for auditory processing are now known to be plastic, and they can take part in sign language processing. And that's why some argue that learning a sign language might accelerate maladaptive cortical organization, so-called visual takeover, which will make cochlear implantation less successful. However, there is no causal evidence for this. Moreover, sign language knowledge actually scaffolds deaf and hard of hearing children in learning to read and write, so it's a good thing. Simply don't worry. When a deaf or hard of hearing child learns a sign language, this visual language will not interfere with spoken language development. Neuromyth 3. The sensitive period for sign language acquisition is longer than the sensitive period for spoken language acquisition, and therefore spoken language acquisition should be given priority. The sensitive period for language acquisition is relevant to both spoken and sign language. In any case, speed is of the essence. Why wait to provide an accessible sign language when delaying language input will have knock-on effects for important and academically relevant aspects of cognition, such as executive functions? This neuromyth might be fueled by a misconception that sign languages are easier to learn than spoken languages because they're less complex and less rich, but that is not true. In fact, children are able to learn both a spoken and a sign language from birth with no adverse consequences. Be aware that early exposure to an accessible language is essential. Cochlear implantation will be more successful the younger a child is, but early implantation should not rule out the child learning a sign language in addition to a spoken language. In conclusion, deaf and hard of hearing children's opportunities for developing good spoken language skills have improved in recent years. However, there's no guarantee that children will be able to gain sufficiently good hearing levels to attain age-appropriate spoken language skills. Many do not. The brain does not actually care whether it's confronted with spoken language or sign language. It just recognizes language, processes it, and learns it. From a neuroscience perspective, the current evidence supports advice that deaf and hard of hearing children should have access to a sign language as young as possible. Thank you for your attention, and please don't hesitate to check out our other videos.